Hello everyone, I am Dr. Sandeep Sharma and I welcome you to this discussion where I am going to tackle, based upon a case scenario, a topic which always creates problems in understanding, that is hemodynamically significant PDA. The discussion is based upon a variety of textbooks. It includes the key points mentioned in the new Nelson 22nd edition as well as the AIMS protocols which have been released this year. I will try to give you useful information which you can understand. Yes, there will be technicalities we will be using, but I will try to keep it as simple as possible and only the things which you need for understanding the disease, understanding the topic, and marking the answer if you get it in the exam. So let us start with the case scenario first of all. So the case scenario goes something like this. There is a preterm neonate, 29 week 5 days, who was delivered by lower segment cesarean section. The indication was maternal toxemia of pregnancy. So the baby was delivered because of maternal indication. The baby was given prophylactic surfactant because it was a preterm child, so it was decided to give surfactant therapy and managed in newborn ICU. He was on IV fluids initially and hemodynamically stable. Normally, we plan a echo after 24 hours, usually around 36 hours or so. But in this child, obviously, because he was in ICU and you also have to look at surfactant has been given. So, and the logistics are also there. So, on day 3, an echo was performed. No harm in that, no problem here. The echo was performed in view of some distress present and bounding pulses present in the patient. So, the child was otherwise stable, but some distress was there and bounding pulses was present. And it is a preterm child, remember. So, echo report revealed an open large PDA with a transductal diameter of 2 millimeters. It is a significantly enlarged ductus arteriosus, and there was a predominant left to right shunt. Remember the funda that if there is a bidirectional shunt in the first 72 hours or so, it does not indicate a significant PDA. Yes, it can or it may remain patent for a long duration, but it is not significant enough. But in case there is a significant pulsatile left to right shunt, that will indicate a likely important significant PDA. And LA to AO ratio was found to be 1.6. We will talk about it in some time. So this is how the report will actually come to you when you are reading a report in a file, in a case scenario, when you are actually seeing a patient. And there were no other structural deformities. He was conservatively managed initially with a repeat echo done 2 days later, showing persistence of the defect with clinical deterioration. Now the important point is child has clinically deteriorated. This is a very, very important point in the form of persistent tachycardia. So what are we dealing with? We are dealing with the PDA. First thing, does the child have hemodynamically significant PDA or not? So the question arises, how do you define, if you get this case scenario, how do you define it? And secondly, would you consider pharmacotherapy or surgical ligation, or do you think that only observation should be fine and conservative management alone you should give without doing any pharmacotherapy or surgical therapy in the patient? The answer to these questions we will discuss in the end of the topic. Let us delve into the topic discussion. Let us try to understand PDA in preterm newborns. So first of all, what is the incidence of PDA? Incidence varies according to the gestational age. So lower the gestational age, more preterm the child is, higher is the risk of PDA. In fact, there is a condition known as term PDA, but we now know that majority of preterm children will have some degree of delayed closure of the ductus arteriosus. It is not always required to be treated, but yes, remember that PDA is predominantly a disease of preterm children. About 15 to 40% of very low birth weight infants are found to have a PDA. And incidence of 70 to 80% is seen in these very low birth weight newborns, right? So incidence is 70 to 80%. So very low birth weight means birth weight less than 1.5 kg. About 75% average will have a PDA. Now, whether it will be significant or not, we will see in some time. And what are the risk factors which lead to the abnormal opening of ductus arteriosus? It does not close. First of all, as I told you, preterm child. So preterm baby, low gestational age. You can write in bracket, low gestational age is one of the risk factors. Secondly, in case the baby is having any degree of hypoxia or acidosis. Hypoxia or acidosis. Thirdly, in case there has been an inadvertent use of IV fluids bracket boluses or high normal maintenance value. In case it has a tendency to produce a degree of volume overload, and that can cause delayed closure of the ductus arteriosus in some of the patients. In fact, sometimes physiological closure has happened. It can open up also in case repeated fluid boluses are given to the patient. Apart from that, in case there is a syndrome associated with patent ductus arteriosus, for example, there is a thing called as congenital rubella syndrome. So the chances of PDA being there will be high. And then in case there is excess circulating prostaglandin levels or prostaglandins in the circulation in the newborn due to any reason, that will also does not allow the ductus arteriosus to close. So these are the important risk factors. There is a huge list, but these are the important ones which I have collected from multiple sources at one place. So now the question arises, what is hemodynamically significant PDA? That is what we are going to discuss here. The first question which I had asked at the end of the case scenario. So hemodynamically significant PDA, also called as HS PDA, is an entity which is generally defined echocardiographically and is associated with morbidity and mortality. But you need to understand that it is a very vague term. There are problems with HS PDA because yes, there are some clinical features which raise the suspicion. Echocardiography generally has been considered the investigation of choice to determine HS PDA, but even echocardiographic findings, there is no single parameter which defines HS PDA, and it has been found that different organizations give different values, and even the echocardiographic values vary according to the gestational age and risk factors of the baby. So yes, HS PDA is something which has high mortality, morbidity, and generally, not always, but generally requires therapy. But at the same time, to define HS PDA is another problem by itself. So the problems with HS PDA is there is a lack of uniform definition, I just told you. There is no strict correlation with the decision to start therapy. Generally, HS PDA patients require therapy. But when do you start therapy and how aggressively you start therapy, there is no correlation with HS PDA. And thirdly, echocardiography, just like ultrasound, echocardiography is operator dependent. And if the person performing is a first year JR or a first year senior resident of who has just entered into super specialty, the person will not be that equipped to handle complex cases. And again, echocardiography can be misleading in a few patients. So it cannot be the sole criteria to define HS PDA and treat based upon defining HS PDA. So let us break it down in a simple way. If there is a hemodynamically significant PDA, you need three set of criteria to define. One is clinical suspicion, second, echocardiography, and third, supportive evidence. Supportive evidence is in the form of circulating biomarkers, which we will discuss in the end. Okay, so among them, the most important will be obviously echocardiography. But first of all, to do echo or not and to correlate, you need clinical suspicion. So when would you suspect that a child is having a significant or hemodynamically significant PDA? The child will be having bounding pulses. Now, to check bounding pulse in an infant, particularly a young newborn, we always look for dorsalis pedis artery, right? You know where dorsalis pedis is. Second, you look for pulse pressure in the child. In patients of PDA, there is a relative increase in systolic BP due to increased cardiac output from the left ventricle, and there is a slight decrease in the diastolic BP because of the large left to right shunt. So the diastolic BP tends to fall. The descending aorta has relatively less blood, and so the recoil of the aorta is also less, leading to fall in the diastolic BP. So systolic slightly more, diastolic slightly less. What happens? There is a wide pulse pressure. So wide pulse pressure more than 25 millimeters has been shown to clinically raise the suspicion of HS PDA. Thirdly, when you examine the child, on inspection, there will be a hyperactive precordium. When would you say hyperactive precordium? You look at two intercostal spaces, multiple intercostal spaces, and if more than two have visible pulsations, that is another clue. That is another point. And fourth, in case the child is having persistent tachycardia or systolic murmur, then also we say clinical suspicion is likely to be HS PDA. Now, although you might have read already in your MBBS days that the classic hallmark murmur of PDA is a continuous murmur with machinery character. Remember that continuous machinery murmur may not always be present, particularly in a young preterm neonate with PDA. It tends to appear generally. It can appear in the newborn, but generally it tends to appear in the second month or untreated cases, significant cases, the machinery character becomes more predominant. And that is why if you look at Ames protocol, if you look at most of the standard textbooks, Perloff's Cardiology, they very clearly mention that systolic murmur is what we look for, not these typical continuous machinery murmur. If it is present and there is a PDA, you should suspect it is likely to be a HS PDA. So these are the clinical features which will raise the suspicion. Problem kya hai? These are less sensitive, although they are reasonably specific in the patient. Now, the second tool which I said to define HS PDA is echocardiography. Echocardiography, when we do, what we actually check, suppose there is a suspected patient of PDA or an extreme preterm child, you want to check PDA is there or not. So what exactly are we going to check? We are going to check basically three things. Now this points which I am writing, I am going slow. You may find, see, you all have the access to the forward button as well, the speed increase button. You can always increase the speed, but I would advise just stay with me and listen and understand. I'm going slow because it is a tough thing. When you do echocardiography in PDA, what do we look for? First of all, we look for whether the ductus arteriosus is open or not and what is the characteristic of this open ductus arteriosus. So first thing that we look for is the ductus arteriosus characteristics. So whenever you are doing echocardiography in a suspected PDA patient, you will look for ductus arteriosus characteristics. You will look at ductus arteriosus size. This is something which is not mentioned in Nelson. It is not mentioned in Ames NICU protocol, but it is very, very important. And if you get a PDA case, you may be asked this thing in your viva. So first is ductus arteriosus size. Second, you look at the shunt direction in the patient. Is it a right to left shunt? Is it a left to right shunt? Is it a bidirectional shunt? So you will look at the shunt direction. And third, you will do a color Doppler. Doppler will be done along with echocardiography. So you will do a Doppler study to look at the flow pattern. Second thing you look for, pehle to you will see the ductus arteriosus there or not and what are the characteristics. Second thing, if patent ductus arteriosus is there and there is a left to right shunt, what will happen? Try to think. There is a left to right shunt. Large amount of blood moving from aorta to pulmonary artery. So there will be volume overload on the pulmonary circulation. You understand? Blood moving from LA to pulmonary artery, from there to the lungs. So there is increased pulmonary blood flow. So second feature when you do echocardiography, you look for any evidence of pulmonary over circulation. You look for features which suggest pulmonary over circulation. So what are the features which suggest pulmonary over circulation? You will look at any LA or LV volume overload. Now you will ask me, okay, sir, why are we looking at LA or LV volume overload? Try to track the shunt operating in the patient. There is a PDA. So blood is moving from aorta to pulmonary artery. From pulmonary artery, main pulmonary artery, it is going to the right and left pulmonary artery. It is going to the lungs. Lungs, it is getting oxygenated and coming via the pulmonary veins. All four pulmonary veins open into left side of heart. So if there is increased pulmonary blood flow, there will be more blood reaching LA as well as LV. So you will look for LA or LV volume overload. Second, you will look at a ratio between left atrium to aorta. This LA-AO ratio is a very, very important and sensitive marker we will discuss in some time. It is again a marker. If it is above 1.5, we usually say the patient is having pulmonary volume overload or pulmonary overcirculation feature is present, suggestive of PDA. Thirdly, you will look at left pulmonary artery diastolic velocity. Left pulmonary artery diastolic velocity, it tends to be increased in a patient of significant PDA. And fourth, you will look for left ventricle ejection fraction.